I will talk about ultrasound evaluation of the uterus before the IVF ICSI cycle. We know that steps for IVF cycle consist of controlled ovarian hyperstimulation followed by ovum pickup and embryo transfer. But the most important is evaluation before the cycle because it allows you to optimize the whole cycle. And uterine assessment is one of this evaluation. The aim of my talk is to answer why we evaluate the uterus and how this will affect the cycle and how we use ultrasound to evaluate the uterus. Why we evaluate the uterus? Because the endometrium is the site for implantation, and we know that the uterus is affected by many diseases that affect our outcome: Mullerian anomalies, endometrial polyp, myoma, adenomyosis, intrauterine adhesion. All these affect the outcome. And if we diagnose any of these abnormality, we may think for surgery. We may counsel our patient if the surgery is not indicated about low success rate. We may change our protocol and we may think for single embryo transfer. How we use ultrasound? We use mainly 2D ultrasound. 3D may add something. Saline infusion, sonohysterography, and Doppler may benefit. Before talking about the abnormal, we talk about the normal. We evaluate the uterus in two planes by 2D ultrasound, the sagittal plane and the transverse plane. And in each plane, we evaluate the endometrium and the myometrium. The myometrium are symmetrical, homogeneous. The endometrium thickness and pattern. This is the normal picture of the endometrium in the pre-ovulatory phase. Keep in mind that the endometrium is affected by the cycle. The time you examine your patient, early you evaluate. If you evaluate your patient, it is thin endometrium. Late luteal phase, it is homogeneous and echogenic. If you did 3D ultrasound, you evaluate the uterus in the coronal plane. The coronal plane, you evaluate the endometrium, which is a triangle, and no internal or external indentation, and the myometrium is homogeneous, and the junction zone is intact and regular. If you did saline infusion sonohysterography, you will find no filling defect in sagittal and transverse and coronal plane. Look at the cervix with normal cervical mucus. What is the abnormal? You can find abnormality in the endometrium or in the myometrium. Abnormality is echogenic structure in the endometrium, interrupting the endometrium line. If you add Doppler, you will find single feeding vessel. And if you add saline, this is a picture. And if you add 3D ultrasound, it gives information. The second is the myometrium, myoma in the cavity. It is the same echogenicity of the myometrium. If you add Doppler, it is a circle around it. When you diagnose submucous myoma, you should know type of submucous myoma, either type 0, completely in the cavity, type 1, more than 50% in the cavity, and type 2, less than 50% in the cavity. Saline infusion sonohysterography allow you to know the type, like these cases, totally in the cavity, type 0 myoma, and type 2 myoma, less than 50% in the cavity, and this is a difficult case in hysteroscopic management. 3D ultrasound alone without saline infusion sonohysterography in the luteal phase, you can use the cavity as a contrast to know the type of the submucous myoma. The polyp may be multiple and the myoma also may be multiple. In this case, two pathology at the same time, the myoma echogenicity different than from the polyp echogenic, the myoma echogenicity like the myometrium. What else in the endometrium? You can find the endometrium is thin and irregular, interrupted, with a history of previous surgery in the cavity, DNDC, evacuation, or hysteroscopy, with a history of hypomenorrhea or oligomenorrhea. You can suspect intrauterine adhesion. And if you do 3D without saline, you can map where the adhesion is and the cavity here. And if you add saline, this is a picture, this is the cavity, and this is the adhesion affecting part of the cavity. You can find a thin endometrium, and this thin endometrium will affect the outcome without intrauterine adhesion. We can find intercavitary fluid, which may be related to hydrosalpinx, but more recently it is related to cesarean scar niche. The myometrium has two pathology. The first is intramural myoma, maybe multiple, and it may be type 3 or 4 or 5 or 6. Sometimes you need to add saline infusion to know the difference between type 3, which is contact touching the cavity, and type 2, which is submucous. This is subserous myoma. This is a type of intramural myoma, and 3D may help you to mapping for myoma without saline infusion sonohysterography. The second pathology in the myometrium is adenomyosis, and we know the criteria to diagnose adenomyosis: asymmetrical thickening, the myometrial cyst, the shadowing, the irregular junction zone. This is the myometrial cyst. This is asymmetry between the anterior and posterior wall and linear striation. And this is the normal junction zone, and this is the abnormal junction zone, irregular junction zone, suggesting adenomyosis. Two types, two patients, one with subintramural myoma and one with adenomyosis. The difference: well-defined edge in intramural myoma, ill-defined edge in adenomyosis, and also the Doppler may help you to diagnose. While you evaluate your patient by 2D ultrasound, you evaluate the uterus in the transverse plane. Sometimes when you move your hand from the cervix to the fundus, you can find two cavities suggesting septum, two bodies. But by all guidelines, 3D is considered now the standard for diagnosis of Mullerian anomalies. Why? Because it allows you to diagnose, to visualize the external and internal contour and the shape of the cavity at the same time. And if you find internal indentation, you should measure it and the angle and the thickness and the myometrium above it to diagnose type of Mullerian anomalies. This is arcuate uterus, subseptate uterus, septate uterus, and different shape of uterine septum, different length and width. This is the external indentation by bicorporeal uterus. This is banana-shaped uterus, unicornate uterus, and this is T-shaped uterus. You can at the same time evaluate the cervix for the presence of endocervical polyps. What is new? A trial to diagnose chronic endometritis, which is diagnosed by biopsy and by hysteroscopy by 3D ultrasound. There is one study, one patient, about a correlation between the finding of micropolyps, which is criteria to diagnose chronic endometritis, and finding it by 3D ultrasound. This is new technique. We hope to be validated by research in the next future. After diagnosis of the abnormality by ultrasound, you take your decision what to do: polypectomy, submucous myoma to do myomectomy, intrauterine adhesion to do hysteroscopic adhesion. Age of the patient, number, size, location. Adenomyosis, you counsel our patient about the result. It affects the outcome. You may change your protocol to a long extended protocol like endometriosis. The niche, a big question, we have no answer to repair or not. The septum, a big debate. T-shaped uterus, to do lateral metroplasty or not, a big debate. Unicornate, bicornate uterus, we know that it associated with high risk of preterm labor, so you may think to do single embryo transfer. I suggest reading two papers about what mentioned in the literature about ART and uterine pathology. And in this paper, all the pathology and how to manage according to the evidence and recommendation. And the second about assessment of the uterus with 3D ultrasound in women with ART. My conclusion that ultrasound play an important role in assessment of the uterus before ART. It allows us to optimize our cycle and should be used as a roadmap for hysteroscopic surgery. Thank you.